Hi, this is Becky Davidson. My research question was, does constraint-induced movement therapy improve functional task performance in children with cerebral palsy? Children with hemiplegic cerebral palsy experience functional limitations due to the difficulty they have incorporating their affected upper extremity in activities of daily living. Occupational therapists are uniquely qualified to assist children with hemiplegic cerebral palsy increase their participation through meaningful activities. CIMT is an effective intervention used by therapists to improve upper extremity function of children with hemiplegic cerebral palsy by casting the child's unaffected limb to encourage the use of the affected limb during treatment. Currently, research suggests varying intervention lengths and duration. The variations in intervention protocols need further refinement to determine the optimal amount of time that CIMT should be implemented to improve upper extremity function of a child with hemiplegic cerebral palsy. The first article by Chen et al. Was a level 1 single-blinded randomized control trial that studied 45 children with hemiplegic cerebral palsy aged 6 to 12 years old. The intervention consisted of the child wearing an elastic bandage and restraint mitten on their unaffected upper extremity during home-based treatment sessions that were 3.5 to 4 hours per day, 2 days per week for 4 consecutive weeks. During the intervention, the therapist instructed the child to reach and grasp objects with their affected upper extremity. At the conclusion of the session, the child would then wear the bandage and mitten for an additional 3.5 to 4 hours per day at home during the 4-week treatment duration. The control group received functional, unilateral, or bimanual arm training based on motor learning and neurodevelopmental training principles. This article showed statistically significant improvements in the child's affected upper extremity in grasping, self-care, reaction, and normalized movement time. The limitations of this study were the use of the BOTMP and PDMS-II, since these assessments allow the child to use their preferred hand during the assessment instead of specifying their affected upper extremity, which doesn't allow for the results to depict improved functional use of the child's affected upper extremity. The second article by Lin et al. Was a level 1 single-blinded randomized control trial that studied 21 children with hemiplegic cerebral palsy ages 2 to 9 years old. The intervention parameters were the same as the first study, with a difference in principles therapists used during treatment. During the intervention, the therapist used repetitive task practice and shaping principles with the child. The control group received individualized therapy and then followed a similar protocol to the experimental group in wearing the elastic bandage on the unaffected upper extremity 3.5 hours per day for 4 weeks. This article showed statistically significant improvement in the child's affected upper extremity in grasping, speed and dexterity, and affected hand function. The limitations of the study included a small sample size and, similarly to the first article, the use of the BOTMP and PDMS-II. The third article by Charles et al. Was a single-blinded randomized control trial, it's level 1, that studied 22 children with hemiplegic cerebral palsy aged 4 to 8 years old. The intervention consisted of the child wearing a sling on the unaffected upper extremity for 6 hours a day during treatment for 10 days. The treatment focused on functional activities, repetitive task practice, and shaping principles. At the conclusion of the 10 days, the child's parents directed a CIMT home program for 6 months. The program required that the child had concentrated use of their affected upper extremity for 2 hours per day without the use of the sling. The comparison group was a true control group and did not receive any treatment. This article showed statistically significant improvements in the child's affected upper extremity efficiency, quality of movement, speed and dexterity, and perceived frequency. There was no statistical significance between the control and experimental group in the child's hand grip strength and 2-point discrimination. The limitations of the study include a small sample size and, similarly to the previous literature reviewed, the use of the BOTMP, allowing the child to use the preferred hand during the assessment. The fourth and final article is by Eliason et al. It's a level 3 non-randomized controlled trial that studied 41 children with hemiplegic cerebral palsy, ranging in age from 18 months to 4 years old. The intervention consisted of the child wearing a restraining glove on their affected hand for 2 hours per day for 2 months during the home care treatment sessions that were child-directed. Before the treatment began, caregivers attended an information session about the intervention. The control group received OT and PT that was specific to the child's needs. Parents and caregivers also received information on gross motor function, ADL training, and maintaining musculoskeletal status. This article showed statistical significance between the control and intervention groups in the child's ability to incorporate their affected upper extremity and bimanual activities. The limitations of this study were the non-randomization of subjects as well as the publication year of the article being over 10 years old. Thank you for listening.